Hello, everyone, and welcome to our third session, working with the FACE team and Dementia Training Australia. It's great to have you here tonight. So tonight we're going to be covering some interesting and sort of more tricky but common cases that we come across in general practice. And tonight we have with us an esteemed panel. My name's Rebecca Moore. I'm a GP. I work in Newcastle. I have a special interest in geriatrics and in dementia, and I'm joined tonight by geriatrician Dr. Mark Yates, esteemed practice nurse Carolyn Gibson, and Dr. Stephanie Daley, a GP in Adelaide. And I might just ask them to tell us a bit about themselves. Mark, can you start?
Hi guys, how are you? Welcome, and very pleased to have you here in our third session. I'm a geriatrician based in Ballarat. I run a cognitive dementia and memory service. I work in some residential care, doing a residential inreach, and I've got a deep interest in dementia and supporting primary care take a lead in diagnosing dementia so we can improve the data sets that we've got because they drive our funding.
Thank you. And Carolyn.
Hi, I'm Caroline. I'm also in the Ballarat area, work with Mark on occasion. And I'm a community nurse, and I have worked as a general practice nurse and other roles, care coordination in the community. And I'm also doing my PhD in the role of nurses in primary care, caring for people with dementia. And I'm really interested in the role of nurses and the place for care in looking after people with dementia in the community. So welcome.
Thank you. And finally, Steph.
Hi, I am a GP based in Adelaide. I run my own cognition clinic, which is sort of GP-facing clinic. And I work in normal general practice, and I also am one of the educators at Dementia Training Australia.
Thank you. And so the purpose of tonight really is to provide a platform for you to be able to ask us as many questions as you'd like. Particularly, we're going to use a structure of 3 cases, but we're here to answer your questions, and we'd encourage you to write questions in the chat box, which we'll keep monitoring. So before we go any further, I'd just like to acknowledge the traditional custodians of the lands on which we're meeting today, and we pay our respects to the elders past and present and extend that respect to all First Nation peoples with us today. So hopefully you've already been to sessions 1 and sessions 2, in which we talked a bit about how to make a diagnosis, and then once a diagnosis has been made, what we can do to start instituting care following a diagnosis. And I hope from those sessions that you're starting to feel a little bit more comfortable and familiar with the concept of discussing dementia with your patients and with their family, and also recognising perhaps some subtle changes that might be occurring, which perhaps in the past you might not have thought much of. So Mark, can you talk to us a little bit about what a timely diagnosis is and what some of the benefits might be?
Yeah, a timely diagnosis has been defined by a number of people, but I think the most important definition is to diagnose dementia or cognitive impairment more broadly, and I'll come back to that with the idea about mild cognitive impairment, but diagnosing cognitive change when it becomes a problem to the patient or the person who's coming or those around them. And that arises from this idea that there isn't any real value in just screening everybody over the age of 65 willy-nilly, because in fact the screening tests have a low specificity when we just screen randomly, but their specificity and their sensitivity is much better when we screen people who are presenting with a concern. The problem with that is that sometimes we miss those concerns unless we work with the team.
Yeah, that's great. And so, Steph, what do you see as some of the benefits if we can get that early diagnosis?
Well, In the very early stages, perhaps in the mild cognitive impairment stage or very early stages of dementia, it's possible for people to learn sort of workarounds to enable them to manage their independence a bit better. So that might be through the use of assistive technology, or it might be just changing the way that people do things through using calendars or prompts or reminders. And that not only empowers the person to feel a bit more confident at a time when they can feel really anxious about the fact that they're having these changes in their cognition, but it also provides the ability to maintain independence and stay at home for longer. And also in doing those things and using your brain, I feel that's also a kind of method of cognitive stimulation. And so that also slows down the decline. And so there's, you know, that just in itself in terms of helping people's symptoms. And then there are all the other benefits in terms of allowing people to plan their lives, you know, make decisions about, you know, advanced care directives and care planning, and, you know, changes to wills if that's appropriate, and also then just living a really positive life. So in my opinion, there are lots of positives to making the diagnosis, and it's about how we explain that to the people that we see in clinic.
Yes, and in fact, that's one of the cases.
Yeah, there's a couple of, well, can I add, I'd just like to add to that, perhaps with my hospital's hat on, and that is that identifying cognitive impairment, particularly dementia, really does help the person within the healthcare system, because it alerts the healthcare system to a need. So home care packages, for instance, get a bit of extra dollars attached if there's a diagnosis of dementia, but hospitals should, and you know, maybe they don't always, but they should change their care process to support someone who's coming into hospital with a known dementia or cognitive impairment. And so I think that if we can, and also I guess it probably alerts the whole system to manage those chronic diseases which come with the person with dementia. So a practice nurse, for instance, who knows there's a cognitive impairment may change the way they deal with the repeat chronic disease management, so that we avoid hospital admissions, because in doing that, we avoid further cognitive decline, because we know that delirium is associated with hospital admissions and delirium is associated with cognitive decline.
Yeah, that's an excellent point. And I think it's really important to stress too the importance of good documentation and making sure that cognitive impairment and dementia are actually on the list in their past medical history as well. So we also spoke somewhat about risk reduction measures. Carolyn, in your role as community nurse and practice nurse, what sort of things can you do to help in terms of risk reduction?
Well, I think when you think, and I'm pleased to know there's some nurses in the audience today, that a lot of our role is around health promotion as nurses, and also as, you know, in primary care. And we're always having those conversations with people about heart health, smoking cessation, for example. Are you using your puffer with a spacer? We do it opportunistically, and we do it in formal settings like your care plans and your health assessments. So I think there's a real opportunity to know what 14 modifiable risk factors are, and to introduce those and just keep introducing them early, have the conversations regularly. And I also think that has the benefit of making conversations about cognition easier, and perhaps making people feel more comfortable talking about it, and then they might bring up their concerns earlier. And you were talking about time of diagnosis, that can help support that by decreasing maybe stigma and anxiety about the conversation. So I think nurses have a really big role at every moment, every contact, to have health promotion role.
Yeah, I completely agree. So we spoke during the last two sessions about making the diagnosis. And this involves predominantly history. So about 80% of the diagnosis comes from a history. It comes from a history both from the person who may have noticed the changes, as well as a collateral history, usually from a family member or somebody close to them that knows them. We would perform a physical examination. Now, the history that we're looking for in making a diagnosis of dementia ensures that we're seeing somebody who has had cognitive changes that are of gradual onset, that are progressive, that affect function in terms of daily living, activities of daily living being significantly impaired to make a diagnosis of dementia. and are not caused by anything else. And so by anything else, we're looking for things like excluding a delirium, making sure there's no medication that might be affecting cognition, or making sure that the person's not drinking heavily or withdrawing from alcohol, considering other organic causes. So, and that's where our examination and our investigation really comes to the fore. So during the examination, we're looking to address any vascular risk factors, looking at vital signs, looking to see if weight has changed significantly, which can be a bit of a red flag, but perhaps somebody's not been looking after themselves as well as they had been. And also doing a focused neurological examination. And then added to that, we're looking at investigations to essentially exclude other causes, so metabolic and endocrine causes like thyroid dysfunction, electrolyte imbalances, and arranging some imaging. In general practice, a CT is sufficient to look at ruling out space-occupying lesions, for example. Now, we're very blessed in general practice that we have that luxury of being able to see somebody over several visits. And often we've also got that beautiful connection that we've been seeing this person or their family for often several years preceding. And so we do have the benefit of time here, time to notice those changes and also time to make the diagnosis ourselves. And so it's okay if the assessment takes multiple visits. In fact, we would encourage that. It's a bit less anxiety provoking for the person as well. And there are some item numbers available now to us, which do make it a little bit more, do make us a little bit more able to spend the extra time. So there is now an item number 123, I'm sure you're familiar with, which enables you to spend more than 60 minutes and claim for that. And that's where it might be a good opportunity to do some of those cognitive assessments. So we also spoke in the second webinar about post-diagnostic care and what we can do to help this person and their carers during the journey. I think we have a pretty good checklist. Mark, can you tell us about the checklist and where we might be able to access that?
Well, people can access this by using the QR code, or they could go to the Face Dementia site, which has a specific tab at the top for general practice. And all those resources are there. There's two. There's one, a post-MCI diagnosis checklist to run through that. And then there's also a dementia one. And I think the important thing to realise, as mentioned, is that, you can do this over multiple visits over a 6 to 8 week, even longer period of time. And that's both true for this time period, is both true of the diagnostics, the checklist, the post-diagnosis, but also pre, because as much as I mean, it's great to have 60 minutes consults. The economics of general practice, my wife being one, is that the dollars per minute gets a lot less at 60 minutes than it does over 15 to 20. So often it's 20 minutes or 15 minutes that really make the big hit. So you get them on the website and use the QR code.
Yeah, super. I must admit that I use the checklist every time, actually. I just find it a very good thing to make me ensure that I have covered everything. And it's really helpful when you're organising a GP management plan as well to incorporate things on the checklist. All right, so we have 3 cases tonight. Sorry, I'm just going to... So we have 3 cases. The first is to talk about how we might start a conversation about change in cognition and dementia, particularly in a person that perhaps doesn't have as much insight. We are going to talk about driving and dementia, which I think is a very difficult and challenging area in general practice. And then the other very challenging area is capacity. And so we have a case in which we will discuss what capacity is and who should be doing capacity assessments and how they would be performed. So we're going to meet Clive. Sorry. Right. So this is Clive. He's 86 and he's been seeing you over several years for his management of his diabetes and his COPD. You've noticed that his disease control has been slipping with an elevated HbA1c, and he sometimes seems to have got muddled about his COPD puffers and seems quite short of breath. He's had an MMSE done every year in his over 75 health assessment, and 2 years ago he scored 27 out of 30, a year ago 24 out of 30, and this year he scored 21 out of 30. You organised for Clive to come to an appointment to discuss his health assessment and ask him to bring his wife Kim with him. He starts the conversation by asking why you wanted Kim to come along too. I usually see you by myself, Doc, and I don't usually need a babysitter to come with me. I'm fit as a fiddle. What has that nurse been saying about me? All right, well, Caroline, perhaps you can start by explaining how you approach a cognitive assessment in the over 75 health assessment.
And what has that nurse been saying about me? Yeah, okay.
That's right.
What do we say? So the over 75 health assessment is a really good opportunity, I think, to get a good overview of a person. The role in it, like everyone's got templates, but they can differ a little bit. But generally speaking, we cover off your health promotion, like we talked about before, and also preventative health aspects. But there's also a big functional part to it. And I think understanding or recognizing functional change is a really good place to pick up cognitive change. Mm-hmm. And so if you notice someone's, and like someone mentioned before, I think you mentioned before, that longitudinal relationship we have, we can pick up those changes. And we'll know then is someone no longer cooking as much or not able to handle the mobile phone or walking or something like that, or more falls. And I think it also then gives you an opportunity to ask about cognition in a non-threatening way, because you start exploring why the function has changed and trying to get a bit deeper into that. Then it always usually incorporates the MMSE or another cognitive assessment tool. I think it's important to understand that isn't then the cognitive assessment part of the whole assessment. I think the function's giving you the information. The tool is then just going to confirm or maybe add a bit more meat to when you talk to the doctor to say, look, because that's what you're doing at the end, report to the doctor, say, look, I'm concerned there's been some changes here. What that nurse has been saying about me, I will try that one. I think, obviously, naturally, Clive's a bit suspicious. He's obviously a bit anxious, maybe, that he has recognised there's some changes going on and he's just being a bit self-protective, which is fair. And Kim might have been saying some things to him at home and he doesn't want all this disclosed. And I think as the nurse, we would have told him, most probably in the 75 plus, has he gone to the nurse before or after? Or to discuss it, yes. So he's already had the assessment.
Yeah.
So we most probably would have asked Clive, it'd be a good idea to bring Kim in with you. And hopefully you'd couch it in such a way that it's not to check up or check he's telling the truth, which drives me. I'd hate if someone says things like that. But just to maybe get a better picture and keep it positive, that we would like to speak to both of you because we want to make sure that you can keep doing the things you really enjoy doing, and it's a team. And that's how I tend to pose things when I'm talking about bringing others into the conversation, that we're working as a team.
I like that. That's really clever. And in this history, what sort of aspects of his function or his medical health would you see as red flags that perhaps he hasn't been looking after himself as well?
At the top, if his diabetes control is usually good and now it's slipping, I'd be wondering why. Mm-hmm. That could be the use of the glucometer. It's amazing how many people with cognitive impairment might suddenly get a new glucometer because the rep drops a whole lot off or something, and yet they can't use one. It could be that, or it could be from his cooking diet. So to imagine his wife's doing that. He's getting muddled about his puffers. Have they always been the same puffers, or has there been a change? So really I'm looking at changes. So obviously disease control is one of those changes. Then I'd be picking up on functional. And then you get, of course, the MMSE has been going down, but as I said, my driver tends to be more about functional change. And we're asking, you asked before the others about asking about cognition. Asking about function, I think, is a lot easier than asking about cognition, and you can pick up some real good clues that way too.
Yeah, okay, that's very helpful. So, Mark, when someone comes into your room for this initial assessment, how might you start the conversation?
Well, first of all, I'd have to say I am incredibly lucky as a specialist in the field because, of course, these people have been referred to me, so it's a bit unfair, and I'm at a huge advantage courtesy of all the work you guys do. Even so, there's often some anxiety and some concern, and I would always, if I've got to the point there that I'm going to discuss the presence of a cognitive problem, I use graded language. I don't use the term dementia first up. That's absolutely, I always talk about memory and thinking difficulties. And again, it's sort of bringing it back to that functional concept, just to segue from what Caroline said, because it's the memory and the thinking that's the functional problem. And you can avoid the term dementia. If then I'm lucky enough to think this is mild cognitive impairment, then I think that opens up a very positive discussion, knowing that 60% of people with mild cognitive impairment will either stay the same or get better with intervention and support. And we can talk about then all the positive things that we can do around deep prescribing, better management of chronic diseases like the airways disease, etc. But if I think this is dementia, then eventually I'll say, well, we need to talk about some difficult areas. And I mean, I'm in the diagnostic space at this particular point, and the patients have come to me with an expectation of a diagnosis. And so they're sort of expecting something. And then I say, I'm going to talk about dementia and I'm going to talk about Alzheimer's disease. The next thing I ask is actually, do you know what the difference is? And you'll be surprised the amount of people say, look, I don't mind having Alzheimer's disease, but I don't want to have dementia, or vice versa. And so trying to explain that. And I just use a very simple explanation. I say, well, dementia is saying like trees in the bush, and Alzheimer's disease is the gum tree. It's as simple as that, really. And that's where I go. So it's graduated language and opportunities. But I must admit, I'm coming from that advantage of having someone else having had the conversation. So maybe I should defer to my GP colleagues in the audience to work out what you actually say first up, because I might not be very good at it.
Well, how about Steph? How would you approach things?
So I do use the same sort of language as Mark. So I will say, and I also signpost. So I have a specific appointment that I've arranged that is for a cognitive assessment, so that if people have concerns, they can come already to that appointment, raising those concerns. Because actually, I have found since changing my practice that there are a lot of people who do want to talk about it, and they do want to come and have that conversation. And so certainly I would say, if you're a GP starting out, it's better to have the people who are willing to come than the people perhaps like Clive who are a little bit more skeptical of the whole thing. So it's easier to practice your language, I guess, with people that are already coming for that kind of appointment. But if they don't, and it's also sometimes common that perhaps it's a partner or somebody else who's mentioned it, when they're both in the room, I'm kind of quite upfront about it. And I say, look, we're here to talk about your health, and your health includes, your whole body's health, which includes your brain health. And, we need to make sure that all the parts of our body are working correctly, and that includes your brain. And sometimes our brains can be under stress for lots of different reasons, and we need to have a think about what might be affecting the way that our brain is working. And so that might affect our memory and thinking, or it might affect our ability to work out how to get from A to B, or it might affect our visual spatial skills or something like that. And we need to problem solve it to work out what could be causing it, because there are lots of different causes. Some of them are treatable, and there is definitely something we can do about it. And if we don't do anything about it, then things might get worse in terms of the rest of your health, and it might be more difficult to manage. So it's better to be proactive about these things. So I kind of sell it like that it's a good idea, and there's things we can do, and it's a more of a hopeful situation, and hope that people agree. And most of the time it goes okay for me. So I haven't had many situations. There are people who obviously have as part of their symptoms, they will have that loss of insight and they're not able to recognize the symptoms that they're having. That is probably the trickiest scenario. But even in that scenario, I still talk about it in that way, in that, we're here to help you. And whilst it might be something that you yourself haven't recognized or you're not aware of, it is helpful to discuss this with other members of your family so that they can help you, as I'm sure you would want them to be able to do. And so I still sort of talk about it even when they lack insight.
And I do think it's important to capitalize on that opportunity as well, because sometimes it is also quite difficult for these people to actually come in. I certainly have had family members who are worried, but they find it very difficult to get their partner or their mum or dad actually. So making the most of the appointment is a really good idea.
It's also okay to raise it once and then nothing happen, and then have another go at it another time. And some people, I've noticed something and I've been aware of it for a little while, and I've bided my time till I felt it was the right time to bring it up, and then brought it up a little bit, and then waited a bit longer, and then brought it up, because some people just aren't ready to have a full-on conversation. So you're like sowing a little seed and coming back to it and coming back to it, so that you can, because not everybody wants to go the full conversation at the beginning. And that's the beauty of a general practitioner's relationship with their patients, isn't it? Like, we are seeing people on repeat, and we are able to have those more difficult conversations in that way, in little bite-sized chunks. So
yeah, Beck, I might add to that, because I really like that this story is about someone who has had sort of routine or some cognitive assessment done earlier. And I just want to ask Steph, from my point of view, if in fact you've done something previously with a patient and there's an obvious change, do you think that's an opening and therefore an opportunity? Because it really does speak to the opportunities when we get a practice nurse who's sort of feels that there's a bit of a change, but it's not quite sure, but to do cognitive assessment on the basis of the functional abnormalities, because it builds your baseline. And would it be fair to say, if you came in and said, well, Bill, or Clive, sorry, we did this test 12 months ago or 2 years ago, and it was 27, and now it's 21. We just want to make sure you're well.
Yeah. And you can use that as definitely as another way of opening up the conversation. Or the change in his control of, as the other change. I think and you come at it from a perspective of just genuine concern for that person. I think people are appreciative of that, and then trying to, as Caroline said, destigmatize the whole condition, because people bring the stigma to the consult as well, and that is a barrier in and of itself. So
how would you go about that, Steph? What sort of things do you do to destigmatize that?
Well, I suppose that before that, probably the commonest thing people say is, oh, but isn't this just normal aging? Everyone loses their memory as they're getting older. And then I start by demystifying that and saying, no, it's not normal aging. We need to take it seriously. This could be a symptom of something else. And then I talk about how we all have a stereotype in our mind of what somebody living with dementia is, or somebody living with cognitive impairment is. And actually, that's probably not the everyday example. There are many people who are living independently with minimal supports from family, and they're not necessarily living in a nursing home. And where care has changed so much over the last, 30 years, that actually we've managed to enable people a little bit more. And so the whole point of making the diagnosis is to do that for you, to make things a little bit better for you, and to enable you. And so I kind of challenge that stereotype, because I genuinely think that that's what everybody thinks, and the language that people use in the community, that all adds to that. So I kind of challenge that a little bit as well, and try to use appropriate language, because it can be quite.
Do you have any tips? Oh, sorry, Steph. I'm interrupting. I was just going to ask Carolyn, do you have any tips and tricks when you're seeing people in the community for destigmatizing things?
I think that talking about it often in terms of brain health, and also that idea of I try and tap into what's important to people. So what is it they want to keep doing? And you'll usually find a few things that's really important, like keeping on with the gardening and that sort of thing. And so you tie in all their disease, chronic disease to that about keeping well, like Steph said. In order to keep doing things, it's about keeping well, looking at A, B, C, and D to do so you can keep doing it. Get to that cruise next year, get to your granddaughter's wedding. And then the brain part just becomes part of that and keeping it couched in positive terms.
Yeah. Yeah, no, that's good. So one other thing that I come across quite often is, whatever you do, don't put me in a nursing home. And that is often one of the first things that I think people jump to when we're discussing a diagnosis of dementia. Steph, how do you approach that? What sort of tips and tricks do you have at trying to destigmatize that?
Well, I mean, I say, first of all, by having a diagnosis earlier, you might have some choice about what you do and those reasons that you might or might not move into residential care. And then I try and talk about actually sometimes moving into residential care can be a positive thing for some people, actually, because you can become very isolated, actually living on your own. And perhaps if you're away from family, you haven't got that social connection. So for some people, actually moving into residential care can actually be a positive. I've had people who have wanted to go and research and find their own place and have a choice over it. And I think that having that ability to make that choice might be something that people are keen to do. And it might never come to it, but at least you had the ability to say what your preferences were. And I think that's important as well. And not everybody ends up in a nursing home. Some people might die from something else. Some people might actually live with mild cognitive impairment for quite some time and not develop dementia symptoms. If you can keep that person keeping well, then it's possibly, that they, as I said, they may die or they may push it out till they're older. So there's lots of things that we can think about in terms of that. But in reality, if you do end up going into residential care, then maybe you have a choice or you have said what your wishes were.
Yeah.
Beck, I could add to that because
I was going to ask.
I think Steph is absolutely right, but what I tend to first of all say is that 3/4 of people who have dementia are living at home or in the community. They're not in residential care. That's the first thing to say. The second thing to say is that I think the community has a very black view of what dementia is because they only see dementia in its most severe form. Because if you think about how we're struggling making an early diagnosis of dementia, at a community level, the only people that get identified readily by general community with dementia are those who are very impaired. And what they don't see is the population we diagnose who are still actively involved in bowls, still occasionally looking after the grandchildren, still engaged in their community, even though they have a dementia. And I think those are very positive symbols of dementia. And I'd love us to, as a community, be more open about the fact that I've got, and that's what I say to people, you can be a great advocate for dementia because you ought to tell people that you've got dementia because people don't understand how well people can be with dementia.
It's true. Now that's really helpful. So I'm going to move to the next case, unless there's anyone who has any other questions about Clive, or unless you three have anything extra that you think is worth discussing here.
I haven't seen anything about the cases on the chat.
Okay, good. Right. All right. So we're going to meet Jenny now. Jenny is a 77-year-old retired secretary. She's been having significant word-finding difficulties and some memory problems over the last 12 to 18 months. She has well-controlled hypertension and takes 5 milligrams of perindopril. She has some urinary incontinence that has been helped with surgical intervention, physiotherapy, and vaginal estrogen. She's on denosumab for osteoporosis, and she takes regular slow-release paracetamol for osteoarthritis affecting multiple joints. Her vision and hearing are normal. She recently had both cataracts done, and with pride she reports that she stopped smoking on her 70th birthday. She lives alone in a retirement village where she has great support and shows no signs of depression. She has 4 daughters who have helped set her up with automatic bill paying and setting reminders for appointments. She tells you that the last time she went to drive to her daughter's house, it was raining and she got a bit confused over which instrument was the wiper and which was the indicator, and this actually frightened her a bit. So now she's only driving to church, to the doctor, and to do her shopping. She's had no accidents, but she has got some scrapes on her car from getting in and out of her carport. She says, although she doesn't drive much, she would be lost without her car. Her MMSE was 22 out of 30. On the clock face, she had incorrect positioning of the hands of the clock. Her bloods were all normal, and a CT scan shows evidence of chronic small vessel disease. Her geriatric depression scale was normal, and you suspect a dementia syndrome, and you refer for a second opinion and have a diagnosis of Alzheimer's dementia and mixed vascular pathology confirmed. And in the letter back to the GP, it states that she's fit to drive. Now, Mark, is Jenny safe to be driving with an MMSE of 22 out of 30?
Well, I think the most important thing to say here is the MMSE is not a good measure alone. The MMSE alone is not a good measure of driving capability. And it's one of a number of things that I would consider. The clock face drawing is important, and it's a useful add-on to the MMSE because it adds the executive component. But again, that alone is probably not sufficient. It does suggest, if it's incorrect, that she may be a bit what we call stimulus bound. So if, for instance, as many people would have seen, the hands, instead of going, when we say we want the hands at 10 past 11, so the minute hand should be at the 2, we often see the hands are placed at the 10 and the 11 because the stimulus is for 10 and 11. So far, I'm not convinced one way or the other. I'd have to say I'm a little concerned about scrapes on the car, which may suggest that she's got some depth or visuoperceptive difficulties if she's now doing that, but some driveways can be very narrow. And otherwise, I'm not yet convinced.
Yeah, okay, thank you. And so, Steph, as her GP, is there anything that you have to do at this point, at the point at which diagnosis is made in terms of driving?
Well, it depends where you live. So for me in South Australia, there's mandatory reporting. So as the doctor, either the doctor who made the diagnosis or the next doctor who finds out about the diagnosis should report to the authorities. But the onus is primarily on Jenny to let the authorities know as well, so that when she has her annual driving assessment, they are aware of this as an additional medical condition. So it is a reportable medical condition, but in different states, depends on whether the doctor has to report. I think it's only South Australia, actually, that has to. So you guys who are not in South Australia don't need to worry about it.
Well, having said that, you're right, though. It is a conditional, she will need to go to a conditional license.
She does need a conditional license, yeah. But she has to report, unless you really think that she hasn't done the reporting, and then you would have to report as well, I think. And then our role is basically annual assessment, although because it's annual review doesn't mean it has to be annual review. So and I use this technique quite a lot now, so if I'm not really sure, and it can be difficult because especially if you're not really sure of how someone's symptoms are progressing, a year could be quite a long time for some people. So it is reasonable to change that review to 6 monthly or even 3 monthly if you felt the need to. So that is quite a good technique, which I've started to use a fair bit more often now, is rather than waiting 12 months, just reviewing a bit. It's a bit annoying for the patients, but it's safer, I think, so you can get a good gauge as to how someone is going.
Yeah, that's good advice. So let's say she is coming back now and she's due for her driving license assessment. What broad principles would you start with when you're making an assessment of Jenny and whether she's fit to drive or not?
Well, I would probably talk to Caroline about the functional assessment actually, because that's one of the most important things. If I didn't know how she was functioning, I would want to find out, because there is evidence that if you're having difficulty with two of your instrumental activities of daily living, then actually driving might be affected. And certainly if that's progressive, if that functional change is progressive, then you'd be more concerned about whether or not Jenny would be safe driving. So it's really important, even though, and I guess this helps the conversation a little bit actually, because it's not all focused on driving. How are you going with your actual ability to drive? You're asking some other questions about functioning in daily life. You can start with that as an opening to actually starting to talk about driving. And I think that maybe takes a little bit of the pressure off what can be quite a stressful conversation for both the doctor and the person as well.
So Carolyn, what sort of, just to make sure that everyone's aware, what are some of the instrumental activities of daily living that you would be looking at?
I think it's I think just asking about how they're managing day-to-day life and in the community, and just finding out, how they're going with their banking, or, I mean, you're not asking people directly, of course, I'm just saying what the titles are, how they're going with their banking and their grocery, getting to medical appointments, that sort of thing. And if you're actually curious, and if they're having trouble getting to appointments or missing appointments, you can find out, about confidence in driving as well. Just sort of start gathering some clues.
Yeah, I was reading, like you were saying, Steph, if they're having sort of a problem with any area of sort of basic activities of daily living, like grooming, toileting, the real eating, that's probably means that they're not going to be fit to drive. If they're having two or more problems with those more complex instrumental activities of daily living, like you're talking about, Carolyn, then again, that would be a bit of a red flag, because driving requires so many different cognitive functions that, if somebody is struggling to do their grocery shopping, for example, that would be a suggestion that probably they're going to be having difficulties with their driving as well. So that's a good start. And I think, Steph, one thing, or perhaps Mark, one thing that, we always do is start the conversation early. Mark, perhaps you can talk to that a little bit as well.
Yeah, I think it's a really difficult time, and I think it's a risky time for general practice, because relationships can get really damaged by the driving question. I think so there are two ways to deal with that. One is to blame somebody else, and I'll put my hand up as the specialist. If you've got an opportunity to blame the specialist, then find a specialist to blame, because let's face it, every ED intern blames the GP whenever a patient walks in the door. So let's try and change that around. But that's the first thing. The second thing is that it's sometimes useful to almost have rigid. And that's one of the biggest problems about driving, that there aren't any rigid rules. It would be so easy if everybody had to stop driving because their MMSE was less than 22, because that would be just like nobody's going to worry about it. That's great. That's the stuff. But certainly in my practice, I try and work out who needs a driving assessment as part of this, because there's quite a lot you can say about a driving assessment. Often people get threatened by it, but it's done by an occupational therapist, and remembering that they're interested in keeping people doing what they can do despite a disability, rather than just taking people off a road. So they want people with disabilities to be as independent as possible. That's how I discuss it. But I do the clock drawing test. Obviously, that sits with the MMSE. I'd also do Trails B, which we discussed in the session 2, which is the attentional switching task, going from 1 to A to 2 to B. And I describe that in terms of, well, you need to look in your rear vision mirror and the side vision mirror, and you need to think about the kid who's on the footpath, and you need to think about the traffic lights coming up and the car on your in your blind spot. And so you have to switch your attention all the time. And this is a sort of surrogate for that, and we get people to do that. And then we do the Snellgrove maze test. And again, that's like saying, well, there are a number of road rules, and we're going to pretend these are rules, and we want you to navigate this path, and that's, people quite get used to that. without breaking the rules, and see how you can do it. And really, I mean, if people get all three of those fairly well done, then they're going to have no problem with driving. And I'd be quite inclined to say, look, despite I'm making a diagnosis of dementia, I'm going to write in the notes that I think you should have a conditional license. You don't need an OT. And let's see what Vic Roads want to say sometimes. And certainly in Australia, in Victoria, we're not obliged to say anything. But what I say to my patients is, I don't report this because I don't control your license, but if you now know you have a condition that may interfere with your driving, of which dementia is one, then you are required to let Vic Roads know that you have a condition that may interfere with your driving. And then you'll have a conditional license. And then I hold up my glasses and say, well, I've got a conditional license. If I'm not driving with these things on, I'm actually in breach, and my third-party insurance is out the door. And this is what, you know, lots of us have got. If you've got diabetes, you should have a conditional license. So again, it's probably trying to normalize the idea that driving is possible with a disability, which everybody knows it is, because lots of people have had strokes and have had amputees. But driving is possible with dementia as well. But I would always say to people, if I'm going to give them that permission, and I know they've got, say, Alzheimer's disease, which we know is progressive, whereas vascular dementia is a bit of a different story, I would say, why don't you use the next 12 months to work out how you're not going to be driving? Because I think that you have to put reality into the system.
Yes, I think that's right. And I think that's that whole idea, isn't it, of starting the conversation early, planting the seed. You know, what would it mean to you if you weren't able to drive? How would you, what other methods of transport do you have? Who might be able to help you, etc. And I think just starting the wheels turning early is good. So you mentioned vascular and Alzheimer's disease. So, does the type of dementia make a difference when you're deciding if somebody is fit to drive or not?
Yeah, yes, it does. To me, it does. If someone's got Lewy body dementia, and for people who remember the last session, Lewy body dementia is the dementia associated with very significant visuospatial abnormalities, because it starts in the posterior parietal and occipital area, which is our visual cortex. So judging speed and distance can be quite hard early in Lewy body dementia, as well as there's sometimes motor symptoms like Parkinson's disease. But so if someone's got Lewy body dementia, I'm much less inclined to let them drive if they've got a dementia. If they're desperate, anybody who's desperate, I'll get an on-road driving assessment, but I will also inform the on-road driving, the OT, that this is a Lewy body dementia. If it's a vascular dementia, then it's quite tricky, because there are problems with insight and mood. So some people can get quite grumpy and a bit impulsive, and that can be problematic on the road. But other times it's really just that they're a bit slower with their reaction. And if that's not too slow, then I think that's okay. And then they're less likely to progress over time, but they do have that switching difficulty. So vascular dementia, of all people, is sticky. That's what I describe it to them. In other words, switching from one idea to the next is much more difficult if you've got subcortical injury to the brain, because you're needing those subcortical pathways to bounce ideas from one part of your brain to the next. In Alzheimer's disease, early, it's memory that's the problem. And if visuospatial function and language is good, then I'm not so fussed, but I'm aware that that's going to change over time. So that's how I think about it.
That's really interesting. And I'm just interested too. I have seen geriatricians write not to drive at night. Do you have any thoughts on that, or can you explain what the reasoning behind that might be?
Look, I think as one gets older, night driving becomes increasingly difficult because of the presence of cataracts, potentially some subtle floaters and subtle eye difficulties, but also that you're relying a lot more heavily on purely on the visual stimulus, and you've got a very limited sort of area to work with, and so your attention has to be higher. I would always tell any patient who has got dementia first of all, I say, because we're in Ballarat, I say, look, you're not going to drive in Melbourne, are you? And the answer invariably is no, they're not. And I say, that's good. I say, if you can avoid it, don't drive in school drop-off and pick-up times. There's too many mums in Toorak tractors who don't know what they're doing and reading and watching the telephone rather than actually doing anything that they can do to safely drive. And thirdly, I try and avoid, and we're country, dusk and dawn because of animals. That's my advice. But I think you can make that advice, and actually most people start engaging in a positive way to manage their driving. And I think that's really useful.
Yeah. So, I mean, it is about insight. So to some degree, I think, and so a person who has insight, obviously, I think that's somewhat of a relief when you're making the decision. Steph, we've talked previously a bit about collateral history, but what sort of things might you ask family and friends?
Well, I guess how comfortable they feel with their partner or friend driving or parent driving is a really good indicator, and how much of the driving they actually let their partner or friend do, because quite often you'll hear this, well, they don't really drive, I do most of the driving, and there's obviously a reason behind that. And whether or not the person is requiring a sort of co-pilot, somebody who's there saying, well, turn left here, turn right here, how much direction that person is needing. I think all of those kind of parts of the history are really important. And certainly that would all make me a bit concerned, I think, all of those things. I think it's really, one of the things that's really important to do is find out, I think you said it, but how important is driving to the person? And that might not be actually how much do they rely on their car. It might be something about their personal history. So people who have worked in the car industry, or they love cars and they tinker on cars and that's their whole thing, stopping driving. When the car is really important to you as an individual, it's part of your identity. Stopping driving is even harder. And you can pick those people by finding out a bit more about the person. And so those people are going to probably need a driving on-road assessment to help them. More so than somebody who is like, well, I had already thought about giving up driving and I'll probably do it next year, and they're not so attached. So it's emotional attachment to driving, as well as physical need to get from A to B.
Yes, it identifies them sometimes, doesn't it, to some degree, that ability to drive. So when you're talking about driving assessment, just to clarify, we're talking about an OT driving assessment as opposed to a driving assessment through a licensing authority.
Yeah, which is the gold standard. And I think also sometimes explaining to people actually what that entails helps people to make up their mind, because sometimes people are like, well, I don't really want to go through that actually. And they may choose to stop before having that assessment, or sometimes they'll be like, no, I really want to do it. So I think explaining, and I think that would have been covered in session 2 of the webinars, about exactly
good.
what's entailed.
Yes. So just to clarify then, so we would be looking at Jenny from a physical point of view. We would be getting a personal history and a collateral history. We would be looking at the cognitive assessment tools. So definitely involving some visuospatial tasks and something like the trail making task, which would assess changing attention and multitasking essentially, and looking at function too. So people who are able to perform all their usual activities of daily living and pass in those other sections of cognitive assessment, probably would be deemed as fit to drive. Then there's that other area where it's fairly clear they're not fit to drive. And if you have somebody in that grey zone, then you would be looking at either arranging an OT driving assessment or talking to your local geriatrician for some advice on whether they feel this person's fit to drive or not. Does that sound about right? Have I covered most of those things?
Beck, I think there's always one other magic question, which I ask families if they have the opportunity is are you happy for the grandchildren to be driven by gran, which I think is a very important question, because that gives you a bit of a lead. The other thing I've often used, if people are reluctant about an OT driving assessment because they're doing fairly well, there is a high degree of ageism around the community. And if I've had patients who have had a car run into the back of them, and because of their cognitive difficulties, their language has gone out of the window and they can't remember things. And then they've been abused and they are treated badly. And if they've got their OT driving assessment, I say you can roll that up and stick that up the nose of the ageist person who's going to give you a hard time. So I think actually having an OT driving assessment is empowering to some extent. I mean, the risk is that you don't pass it. But on the other hand, there is an empowerment that comes with, I've been so responsible. You're the one who's driven in the back of me. I know I've got an impairment, but I'm responsible enough to do an OT driving assessment. What have you done and why did you drive in the back of me? Well, you were looking at your mobile phone. So I think there's an empowerment to that, which I think is important. And so I like that idea as well. And the other way I try and switch the parameters a bit, if I think that they're wasting their time with an OT driving assessment, in Victoria at least, you can keep your license if you choose not to drive. And that's 70 points of identification. But if you have an OT driving assessment and you don't pass that, then you lose your license and you lose 70 points of identification. So some people like to have their license, and sometimes the license is a problem. It's a bit of a two-way street. But I often say to people, well, maybe you want to keep your license, and if you agree that you're not going to drive anymore, I'm happy with that. And I say, well, then you can give Mary, the wife, your driving license. You can keep it for when you go travelling next if you need ID. But that's not the same. That's not the same for all states.
No, I mean, personally, I'm in New South Wales, and I find it often people get quite confused because they've received a letter about renewing their license, which is the plastic card, and that's different to the letter that they need for a driving medical. And I've certainly had people come in quite confused saying, I just got a new license. I'm like, oh, sorry. Anyway, right. I think then if there's no questions about driving, we'll move to the third case. And so that's looking at capacity. So we're meeting Eleanor, a 77-year-old lady living at home alone. And she has a history of progressive cognitive impairment in the form of short-term memory loss, word-finding difficulties, and difficulties with organisational skills. Her daughter, who lives interstate, is the appointed enduring power of attorney and has automated the banking. These symptoms have been progressive over time, and she's been assessed for a diagnosis of dementia. Her bloods and CT scan are normal. You've excluded all the exclusion criteria, and now you feel she meets the inclusion criteria for a diagnosis of Alzheimer's disease stage 2. The practice nurse and the level 4 home care package manager are both concerned. She has multiple non-healing leg ulcers. She's had weight loss and falls, and they think Eleanor should be in an aged care facility. The case manager has discussed this with Eleanor a few times, but she's adamant she wants to stay at home, and the daughter doesn't want to upset her mum and is reluctant to have her enduring power of attorney to initiate the process of arranging nursing home placement. So the case manager and the nurse have asked you to assess Eleanor's capacity and explain the outcome to her daughter so she can feel supported to help her mum move into a residential care facility. So, Carolyn, perhaps you can start, because I'm sure that this is a case that you've come across previously in the community. What sort of things about this case are concerning to you, and how would you approach this?
Well, starters, it's awful because it's a really difficult situation when you get to this sort of point. First off, I'd like to know, and it's difficult as a practice nurse too, because but if the level home care package of the case manager is concerned as well, and the practice nurse, sounds like there's some sort of relationship there. They are communicating. It'd be interesting to know what services are being provided under the home care package first, because you always want to keep people at home. So are there services being offered that actually help manage the situation, or are we getting services paid for that we might need? Because of course there's only a certain amount of money in the package. Have they got the extra bit of funding? But that's not done as a practice nurse, really. But my first one would be, obviously there's an issue. If she used to look after the leg ulcers quite well and maintain other things, these have been changes. There's obviously a problem. What services are in place? Are they the right services to be most beneficial? I'm not sure what else the nurse can really do here if you're looking to actually wanting to shift it. I mean, there's other things too to make sure the daughter's aware about, like Carer Gateway and other support services. There are education sessions around moving someone into residential aged care. And so you'd then be with other people in conversation who are in a similar situation to yourself. There are tricks. I know, working in the community and this sort of thing, there's ways you can approach these conversations that can be more effective and better outcomes than others. But as a practice nurse in their role, they'd be a little bit limited in what they could do. Community nurse roles, we might be able to do a bit more. But yeah. Not sure that's particularly
good.
helpful.
All right. No, that's good. And I think weight loss is always a significant red flag too.
Yeah.
Would you agree with that?
Yeah, I mean, there's obviously something going on. Something's not being managed. I mean, she's not. There's some key things there that are putting her at significant risk.
Yeah.
And so we can't ignore it. But we have to work out, my approach first is, there something we can do to keep her at home first? And if not, then how can we help ease that transition? And there are people out there that are able to help with that, and Carer Gateway would be where to start.
Yeah, that's good. That's good help. So, Mark, I find it quite frustrating because I know from state to state the terminology varies, but can you perhaps run us through?
I think we've just lost Rebecca.
Oh, sorry.
You disappeared. You disappeared for a second. Are you back?
We missed the first half of the question.
So I think I'll just follow.
Sorry, I'm back. This. Yeah, tell us about the differences from state to state.
Well, I think, first of all, even though there are some state differences, I'll mention those first. So enduring power of attorney in Victoria is about financial and lifestyle. So that's an enduring power of attorney in Victoria can help and support the person as a parent would support a child. So those are the types of decisions. A very powerful enduring power of attorney. And then we have a separate medical treatment decision maker, and that's the Victorian process. New South Wales, they have lifestyle and health decisions. And I think that's a guardian based rather than a enduring power of attorney. I'm not sure.
Yeah, that's correct.
That's correct. So, but I think there are fundamental principles that are the same nationally, because there are national principles about capacity. And the first thing is that it's a human right for each individual to be assumed to have capacity. So the question is, why would we challenge somebody's capacity? Because in fact, it's like being you're held innocent until proven guilty. You have capacity until you've proven you've not got it. So the question is, what is the trigger to challenge this lady's capacity? Because that's challenging her human rights if you're going to do it. And okay, that's because there is concern that she's not got healing ulcers and she's got weight loss and falls. And I'm assuming on the basis of that medical care has been such that those should be healing and she shouldn't be losing weight and she shouldn't be having falls. So her blood pressure is not dropping out of its boots, and she's not got a rip-roaring cancer in front of us, or she's not got multiple, she's not got melanomas or on her legs or something like that. So then the question is, for the daughter, is saying, well, that's your problem, really. I don't want to get involved in this, what the daughter's saying. You deal with it, because I don't want to act on my enduring power of attorney. So first of all, people have assumed to have the right capacity, but also then remember, capacity has to be assessed on a specific issue. So the question is, what are we going to assess this capacity about? And I think probably the best place to go there is actually the falls events. Falls tend to carry a lot of emotional baggage with it, principally because if people fall, sometimes they can't get off the deck and then an ambulance is called. But equally, people can choose to fall at home if they feel they're not going to injure themselves. And if in fact that's what they want, they're prepared to take the risk of falling rather than the risk of being in a nursing home. And remember, if you're in a nursing home, there's no guarantee you won't fall anyway. So why am I going to the nursing home? So I think you've got to think about what the purpose and what capacity question we're asking. Because I would say to this lady, for instance, if I was going to assess her capacity in relation to falls, I'd say, well, we're really worried about you injuring yourself when you fall over. You might break a hip. And then she might say, and your daughter's very worried about you. And she might say, I know my daughter's worried about me. She's living up in Queensland and she does a great job, but she's not here all the time. And if I fall over, so far I've fallen over 4 times and I've not broken any bones yet, and I don't think I'm going to break a bone. And what's more, if I break a bone, I've been at home and that's what I wanted to be. Okay. Does she have capacity? Sounding like she's thought about the issues for the daughter. She's understood the risks for herself. So I think that we've got to make sure that we understand what issue we've got. And the capacity is present if they can, the capacity is the person can understand the information relevant to the decision. So we've asked her, about going to a nursing home because she's falling, but she's saying, well, the reason you want me to go to a nursing home is because I fall over. I understand that, but I don't think my falling, I think my falling is safer, and it's what I prefer to. I prefer to fall at home than fall in a nursing home. And I understand that somebody might not give me a safety link. Oh, okay. Maybe that's what we'll do. And then they'll make that work, and then can retain the information long enough to make the decision. So that's how we go about assessing capacity. And that's what I would do here with this lady. It does sound to me, considering she's got significant Alzheimer's disease, we'd find she would say, oh, I don't fall very much. Okay, then we've got a problem.
Yes, that's right. Yes, so we've talked about the sort of things that we would be looking at in terms of capacity. So that ability to understand the information, the ability to retain the information and use it appropriately, and then the ability to verbalize or to be able to communicate back what the wishes are. Is that right, Mark?
That's right. And there's a really neat book. I'll put it in the chat. It's called The Six Steps to Capacity Assessment. It's written by a guy called Petros Darzens, who's a geriatrician in Victoria.
Yeah. And as you mentioned too, it's sort of very decision dependent. So, so the decision on what you might like for breakfast is going to be quite different to whether or not you'd like to be going, you feel that you need to be going into a nursing home. So again, very decision specific. So I know in general practice, it can be quite a confronting thing. Steph, how do you manage these discussions around capacity? And what do you think our role in general practice is?
Well, I'm going to rewind a little bit to thinking back to Clive, because the opportunity that we have is to actually find out what Eleanor's wishes would have been when she gets to this situation, if we make that possible by having that conversation earlier on. So actually, we may have been able to find out from Elena and her daughter, who may have been present at an appointment, let's have a conversation about advanced care planning. What if you get to the stage when you are having falls, or you are at this point? Is that a point when you would want to live in a residential home? Do advanced care planning properly. Like, we know the situations that people are going to experience with dementia as it progresses. So why not have a conversation about what people feel about that? And then we can honour Elena's wishes. So if her wishes are at this point to stay at home with as many supports as possible for as long as possible, then maybe we would work to make that happen. If she had said, at the point when I'm really that dependent on other people, and I'm, I am, not able to look after my own health, and I am having falls, and that, there is that deterioration, then I think that is the time when I should go into care. That would make this situation a lot easier to understand, wouldn't it? And really, the daughter is there advocating for her mum, in her best interests, and unless she's had those conversations, she's not going to be able to do that. So I would say we need to think about the goals of care for Elena and what they were, if we know those, and that we probably might have done as the general practitioner. So although capacity can be a scary concept, what we're actually doing is trying to work out where that person is in relation to their goals of care, and do they understand what's happening around them to be able to make that decision themselves, or are we looking to that substitute decision maker to act in their best interests? And that's what we need to do. And sometimes I think family members do really struggle to know how to do that, because they feel, you know, that they feel they've got this burden of making the decisions for their loved one or for the person that they've been charged with doing that for. And you know, maybe that's because the conversation wasn't had in depth in the first place. And it's really challenging. I've just done this with my own dad, and I've had the conversation with him about all the different options, and it's really, really difficult. But at least I know now what his red lines are. I know where he's at, and I hope that will make it easier for me if I ever am in a situation where I have to advocate for him. So that's what I think. And I think, you know, capacity is hard for us in primary care. If we're having difficulty with it, especially if it's something about testamentary capacity or something financial, that is the ballpark of Mark and other specialist people and the lawyers. Like, we don't need to get involved in that. So, you know, we can probably do some of this more health and lifestyle capacity if we feel able to. But if you don't, it's okay to get advice, because these decisions are tricky to make on your own. And I think that as a general practitioner, we do sometimes feel isolated in our room and needing that bounce off conversation with someone else. And it's okay to ring someone and say, what would you do in this situation? Or would you mind having a look at this, or getting the community Jerry's team to have a look or something?
Yeah.
Depending on what you've got in your local area.
Yes. And so if a lawyer did ask you to sort of sign a form on capacity, is that something that you would consider?
No. In fact, lawyers are actually trained to assess capacity themselves. So they should, and if they're in any doubt, then they should be getting a specialist opinion. So I think writing, you know, unless you are absolutely 110% sure this person didn't have anything wrong with them. But, you know, if you've got any concerns, it's really hard for us to, because we don't know what the details of somebody else's will. Like, actually, testamentary capacity is really complex, because people have got to make very complex decisions about multiple scenarios. And, you know, I don't think that that's necessarily something we as health practitioners have the ability to assess capacity for, because it's not our area of expertise.
Yeah, no, I mean, I agree. And I think these are some of the most challenging areas that we come across. Mark, what happens if she didn't have a substitute decision maker appointed at all?
Well, I mean, I think then you've got to make a decision about whether she has capacity to appoint a substitute decision maker. And I think we do become a bit involved in that. So just to clarify, I mean, and also support there what Steph has just said, I get this, and I get it even as a specialist. Oh, can you know, and I get GPs who, I get it said to me after this, gone to the GP, oh, I've been asked by a lawyer to say this person's got testamentary capacity. Well, just say no. Just say no. It is not your job as a doctor to say that someone has got testamentary capacity. The lawyers are actually, they amortize. Why do the lawyers expect $400 every time they get someone to write a will? Because they amortize the risk of going to court. Because if you go to court, you don't get paid for it. So they decide, well, if I'm going to see 100 people with capacity, I'm going to get paid $400 for each of them. Then if one of them ends up in court, I've probably covered my costs. And what are GPs asked to, and what are we as a specialist asked to for $100? You know, say someone's got capacity, so don't do it. Capacity testamentary is a legal question, not a medical question. What you could be asked is this person as well as possible to come and see me to provide testamentary capacity? And then you can provide, say, well, no, the cardiac failure is not right, and we can do this and we'll do that. We'll just get them as well as we can, but then they're yours. So that's the first thing. When it comes down to whether someone has got an enduring power, capacity of enduring power of attorney, again, in Victoria, it says that it has to have two people as witnesses. And then it says the first one is a doctor. Well, that's not true. That's an example of someone who can. It can be any person who can sign an affidavit. So there could be a justice of the peace. So don't be fooled by the documentation. You don't have to be the one who signs. But it's nice if you can, because if it's someone like Clive, who's got an MMSE that's pretty straightforward, and he's got nothing much else here but his retirement package and his and he's not married 16 times, and he hasn't got a portfolio worth $16 million, and he's not Lachlan Murdoch's dad, who needs a capacity assessment, it's easy and you don't have to worry too much. So I always say, look, and if this lady, for instance, the only thing in life, she's only got one daughter, she's not married 3 times, she's been in a council or a council house all her life, and the only income she's got is her pension. The decision she has to make, or she's giving over to her daughter, is really very small. It is about going into residential care, which is big, but ultimately after that, the decisions are about how that money that she's got in a pension will be distributed, but most of it's going into residential care. And there's nobody else to complain about what's happening to this lady, because the daughter's the only person who really cares for her in the world anyway. So why wouldn't you say go ahead and have enduring power of attorney? What's the risk? Elder abuse is a risk, and there's been a recent discussion in the radio now about that. But this daughter has been doing her darndest to help her mum from far away, so I think there's probably genuine. And secondly, then the only other risk is that somebody complains that she has got that the daughter's got the enduring power of attorney. But if she's the only person in the world who cares about this particular individual, it's unlikely there'll be a complaint. So again, this is like going back to, well, does she have capacity to choose to have milk or sugar in her coffee? Of course she does. Does she have the capacity to choose that the only person in the world who cares about her should be her enduring power of attorney because there's nobody else who could be? I think she does. Because it's a lot easier than going through VCAT for her personally and for her family.
Yeah, good. I mean, so just hypothetically, if you feel that the person is not acting in their parents' best interests, do you have any recourse there?
You do. So if in fact the enduring power of attorney was constructed and written when the person had full capacity, okay, and then this person's not acting in their best interests, it's more challenging, but you can seek support from VCAT. You can challenge their enduring power of attorney on the basis that the reason an enduring power of attorney is there is to act in the best interests of the patient. Now, the problem would be is if one sort of the enduring power of attorney was held by one half daughter and the other half, the adopted daughter, says, I don't like the fact that you are spending, I don't know, $200 a year on accounting for your enduring power of attorney, you shouldn't do that, or whatever it's going to be. Or it could be that half daughter's decided to buy a car for herself because she takes mum to appointments on a regular basis. She didn't have a car. That all gets a bit tricky. If the enduring power of attorney has decided to take half of mum's estate and put it on a deposit for her son's apartment in Sydney, then that would be not acting within the interests of the patient, and therefore that would be challengeable, and that goes to VCAT.
Yeah. Yes, it's a murky area, but I hope that we've covered some of those issues for you. So certainly in terms of capacity, we're looking at making sure it's decision specific. Does the person understand what the discussion's about? Can they retain the knowledge, and are they able to communicate back to you what they would like? I think the GP's role is if there is significant concern about capacity and it's not something that you feel comfortable with, then that would be something to discuss with colleagues and essentially to seek specialist opinion. And in terms of testamentary capacity, that's a legal decision and that should be done through the lawyer. So do you feel like I've covered that all right, Mark?
Perfect. I think that's very good.
All right. Good. So has anyone on the panel got anything further that they think needs to be discussed in terms of capacity? No. Right, lovely. And do we have any questions from the chat? You've been remarkably quiet. I hope that means we're covering everything as we speak, but by all means, now's the time to ask, because otherwise I think we're coming close to the close.
There's no
any
questions.
other questions?
No questions that I can see.
No questions. Super. All right. Well, we would recommend that, please, if you can scan this QR code to help us by evaluating the session. I'll leave that up there for a second.
Please do it, because we really do. We do try and understand how best to share this information with you, and then get it better as we go. And this is the evaluation from the face dementia program, and this education plus the resources that you might see on the website.
That's super. And I think Jade's just put on the chat box the survey as well.
Right.
And then just moving forward. So again, these are some fantastic resources that are provided by FACE. I would strongly recommend using these resources. That includes those checklists that we were talking about.
I might just comment that the videos are really good. Get you involved, your receptionist staff, and also that's recognizing cognitive impairment. This is the receptionist and practice staff, and also general practice. I'm actually not. I finished doing the problem solving with a geriatrician, so those drop-in sessions have now completed. So the other things are all available to you, and the QR code will get you straight there, or you can follow the link that's on the slide.
Fantastic. Well, thank you very much. Thank you to Mark, Carolyn, and Steph tonight. And I hope that that's covered many of the tricky challenges that you might face.